Game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young at heart. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet. It's not over yet. And even when you think you're finished, it's not over yet. It's not over yet. Keep on fighting out of the dark into the light. It's not over. Hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, and life is a race we run. So run till the race is won. Don't you ever give up. No, never give up. Life is a race we run. So run till the race is won. Don't you ever give up. We will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet. It's not over yet. And even when you think you're finished, it's not over yet. It's not over yet. Keep on fighting out of the dark into the light. It's not over. Hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet. It's not over yet. And even when you think you're finished, it's not over yet. It's not over yet. Keep on fighting out of the dark into the light. It's not over. Hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet. It's not over yet. And even when you think you're finished, it's not over yet. It's not over yet. Keep on fighting out of the dark into the light. It's not over. Hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa.
Welcome to another ILAE webinar series. Today we have the pleasure and the honor to present the ILAE President and University of Calgary Professor Samuel Wiebe, who is going to talk to us about pre-surgical assessment and surgical options in epilepsy. Dr. Wiebe completed his MD degree at the University of Guadalajara in Mexico and specialized in internal medicine at the National University of Mexico. He trained in neurology, epilepsy, and electrophysiology at the University of Western Ontario, Canada, followed by a master's degree in clinical epidemiology and biostatistics at McMaster University in Canada. He served as director of the Epilepsy program at Western University in London, Ontario, Canada, where he also founded the evidence-based neurology program. He then became head of neurology and associate dean of clinical research at the Cumming School of Medicine, University of Calgary. He's currently director of the Calgary Comprehensive Epilepsy Program, professor of clinical neurosciences, and chair of the clinical research unit at the Cumming School of Medicine, University of Calgary. He's a fellow of the Canadian Academy of Health Sciences. In the International League Against Epilepsy, he has served as president of the Canadian League Against Epilepsy and as chair of the North American Commission of the ILAE, Secretary General of ILAE from 2009 to 2013, Treasurer of the ILAE from 2013 to 2017, and is currently the President of ILAE. Professor Wiebe's academic and research interests include epilepsy, health services research, health informatics, outcomes research, and evidence-based medicine. He conducted the first randomized controlled trial of surgical versus medical therapy of temporal lobe epilepsy, has published over 300 peer-reviewed articles, and has given over 250 international lectures. Dr. Wiebe has mentored numerous national and international clinicians and researchers who have gone on to become successful leaders in their own right. The learning objectives of today's presentation are the following: to demonstrate working knowledge of indications for pre-surgical evaluations, describe the importance of early surgical intervention regarding neurodevelopmental, cognitive, behavioral, and social integration aspects, demonstrate working knowledge of etiologies amenable to surgical treatment and their prognosis in all age groups, demonstrate knowledge about the risks and benefits associated with drug management, demonstrate working knowledge of post-surgical neurological and psychiatric complications, identify situations which require consideration of repeated surgery, identify situations which require rehabilitation following surgery, and demonstrate the value and need for multidisciplinary teamwork. Thank you very much for coming, Dr. Wiebe, and we are looking forward to listening to your presentation.
Thank you very much, Christina, for the kind introduction. Thank you to Yes for, number one, for putting together this great webinar series, and also for inviting me to participate in this particular one. I would like to mention that the list of learning objectives that Christina just kindly read is quite extensive, and it's very difficult to cover everything in one talk. So I think that a slightly revised list of learning objectives would be to understand when a patient needs to have video EEG monitoring, to understand the indications for intracranial EEG investigations and the role of various investigations in presurgical evaluation, and then understand the risk-benefit assessment of those aspects. So if we could at least understand those things at the end of the talk, that I think we are a step ahead. So let's start right away with the definition of drug-resistant epilepsy, which we are all familiar with. We know that it requires failure to achieve complete seizure freedom with adequate trials of 2 appropriately used anti-epileptic drugs, and we need to have informative trials in order to be able to assess that. And they can be used as monotherapy or in combination and the person needs to be seizure-free for 1 year or 3 times the longest prior seizure-free interval, whichever is longer. So when we encounter this patient, we face a number of situations, but I would like to first mention 2 important caveats, and this is referral to epilepsy programs. Referral for epilepsy programs is not limited to presurgical evaluation. I realize that this is the title of the talk, but I think it's, especially in these times of the pandemic, there has been important restriction of services for epilepsy patients. And it is important to understand that evaluation in a specialized epilepsy program is not limited to presurgical evaluation. You also use it for cases of diagnostic uncertainty, characterizing epilepsy and seizures, optimizing treatment, addressing comorbidities, and then offering advanced therapeutics. I will show you an example of the impact of a specialized epilepsy program first. This is a 15-year cohort of 4 million people living in the province where I live in Canada, in Alberta. And we looked at the risk of mortality if patients with epilepsy, from the moment they are diagnosed, following them forward over 15 years, whether the risk of mortality differed if they were seen just by a GP, non-specialist, if they were seen by a neurologist, or if they received care in a specialized epilepsy program. And these are the results. This is a cumulative risk of mortality you can see here. This is the risk of mortality if patients are seen by generalists, no neurologists. The risk decreases substantially if they are seen by a neurologist. And then it is lowest if they are seen in a specialized epilepsy program. We took a lot of pain to make sure that we did not have biased assessments and there were no other confounders explaining this. But after numerous analyses, and you can find the publication in JAMA Neurology, there was no question that this was related to care in a tertiary care epilepsy program. And these are the factors that were important in influencing mortality. There was a substantial decrease in the hazard ratio if seen in an epilepsy program, then little less neurologist. And then also age was important. The older the person, the higher the risk of death. And then the severity of epilepsy, of course, as measured by use of resources. The larger the use of resources in the healthcare system, the higher the risk of death. Now, referral to evaluation for epilepsy surgery itself is fraught with barriers for some reason. This is an interesting study looking at 185 patients with focal epilepsy at a tertiary epilepsy center in Germany. And they had a questionnaire for the neurologist and for the patients. And the questionnaire asked, did you refer for surgical evaluation or not? And for the patients was, did you follow the recommendation for surgical evaluation or not, and why not? And these are the results. The recommendation for non-invasive surgical evaluation occurred in 43% of neurologist visits. Of these, 30% of the patients agreed, which is 13 of the total. And then 10% actually had surgical evaluation, which is really quite an impressive decline in numbers. You can see that it goes from, 10% of the total is really quite a low number. So there are many reasons, but these are some of the reasons. Why do epileptologists do not refer for presurgical evaluation? And the highest reason here is low seizure frequency, or assume that surgery will not be a success, or that the severity of the seizures is not high enough, or that the patients have psychiatric comorbidity, and then others. And we will talk about each one of these in a moment. The other reason is the other side of the equation is the patient's reason for rejecting referral. And you can see here that overall fear of brain surgery is the driving barrier for not accepting presurgical evaluation. A number of reasons, and then the fear of postoperative physical deficits, or assuming that surgery is not going to work. So a lot of this, as you can see, is related to probably misinformation or incomplete information. And these are the independent predictors of not being referred for presurgical evaluation. For the neurologist, the most important one was age, interestingly. The older the neurologist, the less likely he or she would be to refer patients for presurgical evaluation. If the patient had legal guardianship, and then if there was no presurgical evaluation, if that neurologist had not sent a patient for presurgical evaluation earlier. So they just don't send people for presurgical evaluation because that is their practice or culture. For patients, the most important one is having seizures with no impaired awareness. If they had no impaired awareness, they probably did not consider their seizures as severe enough to warrant presurgical evaluation. And then having only focal aware seizures. And interestingly, having tried more than 5 anti-seizure drugs in their lifetime. I would have imagined that this marked a severe form of epilepsy, but yet it was a marker of patients not wanting to proceed with presurgical evaluation. Perhaps they have gotten used to their condition and do not wish to proceed. And then age, the older the patient, the less likely they are to accept. The second caveat that I would like to mention is that video EEG monitoring is not limited to presurgical evaluation. As I said earlier, it is used for diagnostic uncertainty, it is used for treatment optimization, and is used for quantification of EEG abnormalities. It is extremely important to note that patients that do not undergo the necessary video EEG monitoring can have worse outcomes. We now know from several publications that patients with psychogenic non-epileptic attacks have a higher risk of death if they are not diagnosed and treated. We also know that patients can have substantial morbidity and even mortality if they are not adequately investigated. It is important to note that during these times, during this period of restriction and resources for healthcare due to the COVID pandemic, we need to emphasize the importance of preserving the services that epilepsy patients need, including video EEG monitoring, if practiced within the restrictions that our health authorities impose, which is perfectly possible. We have continued in our center to do video EEG monitoring, intracranial electrode implantation and recording, and epilepsy surgery, adhering to the parameters of our health officers for the prevention of the COVID spread. For example, these are some of the uses of video EEG monitoring. This is 131 patients in Australia. And you can see that for diagnostic purposes, 70%, for presurgical evaluation, 30%. So it really is important. You see the rate of non-epileptic diagnoses, non-epileptic seizures before video EEG monitoring, 7%, went up to 30% after video EEG monitoring. So it has a number of advantages. So let's go back to the original question of our objectives. What do you do when you have a drug-resistant patient with disabling seizures? Well, the immediate answer is, well, you find the lesion or you find the epileptogenic zone with MRI, EEG, and then you determine its resectability. And then you resect it or ablate it or electrocoagulate it or disconnect it. And if that is not possible, then you probably do some sort of electrical stimulation or neuromodulation. So it's a fairly straightforward process. But what does this entail? This is extremely important. Well, let's go to the starting point. And the starting point is your initial clinic evaluation. The history of epilepsy is important, the current seizure type and pattern, the drug history failure, any comorbidities that preclude surgery are important to consider. And then neurological examination, EEG, MRI, cardiac investigation, skin assessment for the presence of neurocutaneous abnormalities, and electrocardiogram, etc. And we'll talk about some of these specifically. For example, current seizure type and pattern. Of course, you are interested in knowing whether there are epileptic seizures or not. Important. Also, their semiology, their focality, their frequency, disability, and lifestyle issues. And these two aspects are important because you will remember that in the study from Germany, about 40% of patients were not referred because they were considered to have not frequent enough or not disabling enough seizures. So what is the evidence for that? There is no standard definition of what is a sufficiently frequent or disabling seizure to require presurgical evaluation. Researchers, for the purpose of defining the populations, in the past have used, for example, 20 focal impaired awareness seizures in the past 24 months, or 1 focal impaired awareness seizure per month in the past year, and this is what we use for a randomized controlled trial. But remember, this was just for the purpose of a research study, not necessarily for defining what is disabling or frequent enough. Much lower thresholds are necessary. We need to understand how disabling even less frequent seizures are. We need to, of course, consider conditions such as epileptic encephalopathies in which the intervention needs to be almost urgent to avoid further deterioration. And we need to identify resectable lesions that may be surgically treatable and produce a cure almost for the patient without having to wait. So we need to individualize. What about the history of failure to do anti-seizure drugs? Well, we need to remember that not all uncontrolled epilepsy is drug resistant. About 40% of these patients are undefined really whether they're drug resistant or not. 50% have not tried adequate medications or adequate dosages of medications. And then in about 23%, there is insufficient information. And this is the reference that you can check listed here at the bottom for those data. Comorbidities. Remember that one of the important reasons for not referring patients for evaluation was comorbidities that may preclude surgery. What are those comorbidities? Well, we find that increasingly the list is very small. The list is shrinking. There are very few psychiatric conditions that really preclude pre-surgical evaluation. We could probably say that acute psychiatric crises may be a condition that does not allow evaluation. Another one would be a situation where the psychiatric condition does not permit the patient to undergo the investigations because they cannot stay in the hospital or they will not adhere to the issues. The other one is neurodegenerative conditions, and that is correct. We try to avoid doing epilepsy surgery on neurodegenerative conditions. However, if the process is very, very long and the patient can benefit, that can also be a possible candidate. Life-threatening disease with short lifetime expectancies, and then bad vasculopathies, where the surgeon will be worried that they will create a vascular disaster if they manipulate the very poor vasculature of the brain. And then severe substance abuse. This is interesting because the only reason not to do pre-surgical evaluation here is if the patient cannot stay in the seizure monitoring unit or undergo the investigations. I really don't, it's a condition, it's important, by why preclude surgery in these patients? Because they have this other disease. I don't see any particular reason other than the interference with the investigations. And then others may come to mind. So you have your initial clinical evaluation. We talked about this. The next question is, what does the patient want? And what the patient wants is determined to a large degree on what the physician wants. Remember that the way we communicate to our patients influences very importantly how they're going to respond to an option. If the patient has a preference for surgical evaluation, we proceed. If they do not, well, then we defer the evaluation. So how do we proceed? Well, then we perform initial investigations, which are non-invasive in all these patients. And these include the typical the typical battery of tests, such as volumetric brain MRI, intraictal and ictal scalp video EEG, prolonged monitoring, cognitive assessment, psychiatric assessment, social and nursing aspects, and so forth. Then once we have all of this investigation, the preliminary review of these data determines the next steps, and they are divided here into 4 categories. But first, let me talk a little bit about MRI. MRI, really structural MRI, is the cornerstone technique for identifying a potentially epileptogenic focus, its location, extent, and its prognostic implications. It also is necessary to identify normal structure and multiple lesions. And there are 3 key elements that determine the usefulness of MRI. One is the type of lesion we're looking for that the patient may have. The other one is the acquisition protocol, the technique for the MRI. And the third one is the interpreter. As you know, non-lesional epilepsy surgery is completely different in its outcome from lesional epilepsy surgery. This is a meta-analysis looking at temporal and extratemporal cases, and you can see that in lesional epilepsy, seizure freedom is about 70% overall, non-lesional about 46%, and this also applies to temporal lobe cases. So this whole thing about an MRI negative patient is really, really important. My friend Fernando Sendes tells me that in his center, the MRI detailed investigation using various modalities, of course, really leaves very few patients that are truly non-lesional. And this is interesting because in this study by von Oertzen in 2002, what was demonstrated is that when the MRI is done using non-specific epilepsy sequences, just a regular brain MRI, not for epilepsy, and is interpreted by a general diagnostic imaging person, a radiologist, the rate of normal MRIs, that means non-lesional, is close to 60%. If that same MRI is interpreted by an expert in epilepsy, that is used to seeing MRIs in epilepsy, the rate of non-lesional MRIs drops to about 28%, 26%. And then if you use an epilepsy-specific protocol, the rate of non-lesional MRIs drops all the way to about 12%. And as these things drop, other abnormalities emerge, like hippocampal sclerosis, a tumor, vascular malformations, etc. So remember, specific sequences and experience in interpreting MRI are crucial. Wellmer, and I'll be going back to this paper quite a bit. You will see this reference a lot in a number of slides, because I think that if you have a chance to go to this paper, go to it. It provides a very good substance for presurgical evaluation in our patients. So they recommend one MRI protocol with a big 6 sequences, which is T1 3D, T2 flare axial and coronal, flare axial and coronal, and then gradient echo or susceptibility weighted imaging and the axial modality with these orientations, et cetera, et cetera. So this is what they recommend. And this is what they find in their analysis of the sequences. So here is the different types of abnormalities, and these are the different sequences. Notice right away that T2 and flare are by far the most informative for all of these abnormalities. Notice also that hippocampal sclerosis, really you need T2 and flare as the most important ones. Notice also that malformations of cortical development are important not only in flare, but also in T1 because of the presence of perventricular nodular heterotopias and other abnormalities, and so on and so forth. An interesting analysis is they looked at the cumulative yield of sequences for the various for any abnormality, and they found that the single highest yield sequence was flare, revealed one abnormality either in about 85% of patients. Then if you added a T2, this increased to 92. If you added a G or SWI, it increased 97%. And then if you added a T1, 99%. So it's an interesting, I'm not suggesting that you only do flare, but it's interesting that you should probably start by looking at the flare and then go to the next sequences when you analyze it. So what to do with non-lesional MRI in focal epilepsy? Well, think about common causes. A non-expert opinion. We always review all MRIs ourselves personally. And then we're fortunate to have radiologists that are highly experienced in epilepsy. Then we go to them. But even if they interpret it, we still review it personally, because I think it's important to review it very, very carefully. Mild mesial temporal sclerosis may be a cause of false non-lesional, and then cortical dysplasias and small low-grade epilepsy-associated tumors. But beware of false positives as well. We can overread MRI, just like we can overread EEG, and we can overread many other things. So what to do if it's non-lesional? Well, repeat the MRI, ask an expert to see it, do thin sections with high definition, look for subtle abnormalities, and focus on the areas that are commonly abnormal, like the frontal lobe, for cortical dysplasias, for example, reformat 3D and add other modalities. This is an example of a false positive. Here you have an asymmetry in the hippocampi, larger on the right, smaller on the left, so possible atrophy. However, this is due to a misorientation or asymmetric orientation cut of the coronal section. Once you make it symmetrical, the hippocampi are normal on both sides. This is another example of missing a lesion. If you don't do thin cuts, this is a small nodule of heterotopia in the ventricle there. If you do thick sections 4 millimeters apart, you will see nothing in front and nothing in the back. If you do thin sections, you will begin to see it here and then see it there, and it is very clear that the lesion is there. This is an example of one of our patients, a 36-year-old man with drug-resistant epilepsy, mandibular jerking, drooling, forced neck extension. So you have an idea where that lesion may be based on the semiology, somewhere along the lower Rolandic region. And he also had focal to bilateral tonic-clonic seizures. You do an MRI, and this is the T1 sequence, and the abnormality is there. But I'm telling you, it's very difficult to see. If you do a T2-weighted sequence, if you look at the T2-weighted sequence, the abnormality is also there, but it is difficult to see. Perhaps you see it by now, but then the flare shows it very clearly, and here it is. It's a cortical dysplasia in the upper bank of the sylvian fissure, as you can see there, and you can also see her in T2, and you can actually see it in T1, but it's more difficult. So the sequences are very important. This patient had an ictal spect, and you can see the hyper perfusion there in the same area as the lesion. So the International League Against Epilepsy has come up with specific recommendations for the structural MRI sequences in patients with epilepsy. And they have what is called a harness, or harmonized neuroimaging epilepsy structure sequences, that are recommended based on the fact that they can be applied to adults and children. They can be done in 1.5 Tesla or 3 Tesla scanners. They do not need operator-dependent slice angulation. They're fairly straightforward. They may be reformatted in any plane without losing resolution, and they improve signal-to-noise ratio and tissue contrast. And it takes about 30 minutes to obtain these, and the 3 sequences are 3D, T1, and FLAIR, and high-resolution T2 images. And with those, you should be able to see most of the abnormalities that are needed. So let's go back to our algorithm. You have your initial investigations, you have all of these things, and then you need to decide based on a review on the next steps. And what are the next steps? So you have 4 possible scenarios. You could have more, but this is a way of thinking about this. One is that no additional tests are needed. You have all the information you need. And when would that be? Well, for example, if you found a hypothalamic hamartoma, then you need to either electrocoagulate it or disconnect it or whatever your technology is at your center needs to be treated. Or you may have a hemispheric lesion without function. Then it's very easy. It's an epileptogenic half of the brain, and you need to either disconnect it or resect it. Or you have a progressive condition such as Rasmussen's encephalitis, and you need to operate, and operate fairly rapidly before the deficits progress. Or you have a generalized epilepsy or multifocal or non-resective, and then you don't need anything else. Your decision is that probably no surgery is needed. The other scenario is that you may require optional testing in patients that have a lesion like mesial temporal sclerosis or Sturge-Weber or discrete tumors that are in non-eloquent areas, a focal cortical dysplasia type 2, vascular malformations, and stroke. Another situation, an increasing complexity where you do need probably additional testing, and this is recommended. And that would be in situations where you suspect a focal cortical dysplasia type 1, tuberous sclerosis with multiple lesions, hemispheric lesions with function, where you cannot just go ahead and disconnect, and then prior surgery that fail and you need to individualize. And then situations where it is mandatory to do additional testing, which is, for example, non-lesional epilepsy, multifocal EEG and MRI, divergent EEG, MRI findings, and eloquent cortex. And what are those tests? Well, here you go. PET, SPECT, functional MRI, 3D source localization. I will talk about that in more detail. When are these tests least useful and most useful? Well, this is one way to think about them. When should you not think of doing PET? Well, if there's already convergent video EEG, MRI data, if you have a large lesion, if there's prior surgery that is going to show only a big hole in the brain with no metabolism because there's a defect, or in tuberous sclerosis where you may have multiple lesions or large lesions. When is it most useful? If you have non-lesional epilepsy, you have divergent data, if the extent of the lesion is not clear. What about SPECT? Well, don't do SPECT if you already have enough information with PET, or if you have multifocal seizure onset. Somebody has 3 different types of seizure onsets, you inject one and you are misleaded because you pursue that one, but there are 2 other foci. Or if it's not feasible, as you can see here. When is it most useful? When you have had prior failed surgery, when you have a large lesion without function, discordant EEG, fMRI, and PET. What about Wada test? I will talk about this in a moment, but we haven't done a Wada test in about 15 years in our center. We don't use it. What about MAG? Well, if the MRI, EEG, or source imaging are sufficient, don't do it. Why do it? Just because you have it, perhaps. But it is useful as a secondary resource, especially if there's a tangential focal spike and in some postoperative cases. MRI reformatting, if the lesions are clear-cut in structural MRI, you don't need to reformat unless you have academic reasons for do that. But it is useful for cortical lesions, especially malformations of cortical development. Specific techniques like arterial spin labeling, EEG, fMRI, and voxel-based morphometry are not routinely used, and they are available in some centers. And then high-frequency oscillations are increasingly being used, but I don't think they are ready for prime time yet, and clinical practice. It depends on the experience in the center, and it depends on having the technology and the personnel. Keep in mind the following. This is an interesting study. I have not seen many like these, but I really like to quote it. It's from 2005 from Korea. And they looked at the impact of 4 different modalities in terms of how much they contributed once they had one that was localizing. This is the percent of seizure-free patients by the number of concordant studies. So if you have no concordant studies, very few patients, but of those, about 25% became seizure-free. And that is perhaps because they had a lesion. I don't know. I do not know the details of these. If you have one concordant study, either one of these concordant with the other, then the number goes up to 44, 45%. If you have 2 concordant modalities, then it goes up to 60%. And more than 2, it really doesn't go much higher than that. So what is the bottom line here? Not because you do more studies, you will find necessarily more concordance ones. 2 are already concordant. Important to keep in mind. What is the sensitivity and specificity of fMRI and MEG versus the gold standard, which is cortical stimulation, to find motor and language cortex in patients and for presurgical evaluation? Well, this is an interesting study, including 19 patients. When they used a distance of 10 millimeters from the cortical stimulation electrode that produced a positive response as being adequately, as being okay. So if the MRI or the MEG identified something that was within 10 millimeters of that electrode, they thought it was all right. You could make it 5 millimeters, which would be much stricter, or you could make it 2 centimeters, which would be probably useless because it's too far. So 10 millimeters is sort of standard to assess this. It is a little sobering to look at the sensitivity and specificity of these conditions. MEG misses most motor points because it has a sensitivity of 14% in this study. fMRI for motor function misses about half of the important motor points. And about a third that it finds are false positive. For language, it's a little better. The MEG misses about 75% of language points, and the fMRI misses about half of the language points. That means that you could perhaps operate and create damage because of inability to identify correctly language points, and also about a third of the points that it identifies are false positive. There is no language there. And that may be related to the fact that the false positives really identify a network that is not essential for language function when tested directly. So this is a little sobering. Keep this in mind. What about language localization in tumor cases, where you have tumor cases and you want to localize because you want to know how far you can resect into the cortex? This is systematic review of 16 studies. If you take all electrodes for all patients, the sensitivity is about 67%. So about 33% false negatives. And then the specificity is 55%. So that means that it misses 45% of potentially resectable sites that could be identified. Right. A few words about the intracarotid amobarbital procedure, or Wada test. I did mention that we do not use it in our center. There are many centers around the world that use it decreasingly or not at all. And there are other centers that cannot conceive of doing epilepsy surgery without a Wada test in patients with a temporal lobe epilepsy. So for language, we have many ways of identifying language, including ictal semiology, postictal function, dichotic listening, fMRI or MEG, eloquent cortex, cortical mapping, etc. So we simply do not use intracarotid amobarbital procedure for language. To predict memory changes, well, we also have a number of robust predictors. So for example, the site of surgery is a predictor. The left or the dominant side will likely result in decrease. Baseline memory function is very important. A high baseline memory function is more likely to result in a decrease in function after dominant temporal resection. A lesion in the hippocampus decreases the chance of a decrease. Cortical dysplasia is important. Older age is important. So the IAP probably does not contribute much to predicting memory changes. We already have that important information. What about situations in which the Wada test predicts a severe decline like global amnesia and it occurs? Well, very few cases. This is reviews from various people, and there's probably about 10 cases in 50 years reported where the Wada test predicted a deficit and occurred. Many of these are in the pre-MRI area, all are in the dominant hemisphere, all had contralateral temporal abnormality, including atypical language, atrophy, et cetera, et cetera. So examine the contralateral hippocampus in detail, pay attention to the baseline neuropsychological testing, look at the MRI carefully, and so forth. And really, you will be able to predict with a sufficient accuracy whether there's a severe risk of amnesia. What about situations in where the Wada test predicts a deficit, but it does not occur? Well, this is very likely underreported. If the Wada test predicted a deficit and it did not occur, it is likely that is of no interest and it doesn't get reported. It's just not interested. There were, by some counts, about 38 cases well documented where the Wada test failed contra or bilaterally. None had amnesia, some had postoperative deficit. But if you don't operate, how can you know if the Wada is correct or not? If the Wada tells you this patient is going to have a deficit and you don't operate, how do you know if it's going to happen or not? So be careful not to exclude patients based on the Wada test if you do the Wada test. And I know that there's a lot of controversy about this, and there would be some people that would strongly disagree with some of these statements. And what if situations where the Wada does not predict and it occurs? Well, there are no reported patients with amnesia post-unilateral temporal lobe resection if the contralateral temporal lobe is normal on high-quality MRI. So why do a Wada test then? And then with bitemporal lesions, we do know that there's already a high risk for memory deficit and so forth. So in summary, very limited or no use. We do not use it at our center, and we don't see any evidence of poor neuropsychological outcomes in relation to that. We talked about the sensitivity and specificity of the fMRI to localize language, and we know that it is not great. What about lateralizing language? Well, that's a different story. The fMRI is excellent, really, to lateralize language. It can tell you which hemisphere it's at with a median concordance with corticography or electrocortical stimulation of 92%. And you can see TIDC range from 69% to 100, many with 100%. And the largest study had a concordance of 86%. So it is really quite good for lateralizing language. Let's go back to our algorithm then. So you have the initial investigations, which are these here, and then you have a preliminary review that determines the next steps, and we already looked at what those testings are. Then you go to the multidisciplinary case conference because that is where the surgical decision is made. And then you have two scenarios. You have a scenario where the patient has generalized or multifocal epilepsy with more than two foci, What options do you have for surgery? Well, it depends on the type of seizures that the patient has. If the patient has predominant drop attacks, then probably you're looking at two types of interventions, either a callosotomy or a vagus nerve stimulation. If the patient has other types of seizures, and then the question is this hemispheric epilepsy or not? If it is hemispheric epilepsy, then you may be looking at hemispheric surgery, like hemispherotomy or hemispheric disconnection. If it is not hemispheric epilepsy, if it is multifocal, then you're probably looking mostly at neurostimulation of some sort, such as vagus nerve stimulation or other types of neurostimulation. What about focal epilepsy? Here, the key issue is how well defined the epileptogenic zone is. You may have enough information for localization, and then you directly know whether it's well defined or not. Or you may need intracranial EEG monitoring with stereo EEG or subdural EEG, whichever is used at the center. And that will tell you whether the epileptogenic zone is well defined or not. Let's talk a little bit about stereo EEG. The problem with stereo EEG, of course, is that the human cortex is a really big place. The surface area is about 2,400 square centimeters. Now consider that the surface explored by a depth electrode is a sphere about 6 millimeters. The surface explored by a subdural electrode disc on the surface of the cortex is about 1 centimeter diameter. So theoretically, we would need from 2,400 to 4,800 contacts to cover the cortex. Of course, we are not interested in the entire cortex, and therefore we use on average from 50 to 180 contacts for the investigation of an individual patient. Why do we use this number? Why can we get away with this in many cases? Well, because we have a clear localization hypothesis of where the electrodes should be implanted. I cannot overemphasize how crucial this is. There is what is called fishing expeditions, where you just put electrodes because the situation is desperate and you just don't know what else to do. But those should be few and far between. So the hypothesis of where to place the electrodes, which is provided by the semiology, the MRI, scalp EEG, and functional imaging, is absolutely crucial. Otherwise, we end up in this scenario where we look where the light is. You know, a gentleman loses his key in the night, and then somebody finds him looking under the lamp, and they say, "Why are you looking here?" And he says, "Well, because this is where the light is." And this is what can happen with intracranial EEG. We're completely biased in terms of where we look if we don't have a good, clear hypothesis. It is good to have in mind some sort of an algorithm for these things. So a possible algorithm, again, this is coming from Wellmer, I mentioned that I would be using this quite a bit, is one situation is where you have a clear lesion, there is congruent semiology, and scalp EEG, and then you don't need anything else. You don't need invasive EEG, and you can go to a surgical decision. The other scenario is where you have a clear lesion, but a little bit of incongruence with semiology or with scalp EEG. This may require minimal invasive implantation to confirm where the epileptogenic zone is. And the same applies if you have a questionable lesion that is not very definitive in the MRI, and then you have congruence with everything else, with semiology, scalp EEG, PET, or SPECT. You may require a bit of intracranial implantation just to make sure that you're in the right spot. And then you have an MRI-guided lesionectomy or extended epileptogenic zone resection. The other situation was a bit more complex. The other scenario is where you have a diffuse lesion, very large or diffuse, but you have congruence with semiology and scalp EEG, for example. In this case, you would require extensive implantation covering all the candidate areas necessary. And the same would apply if you have no lesion or multiple lesions with congruence of semiology, EEG, PET, SPECT in one specific area. Then you would need probably extensive implantation to make sure that the other lesions are not causing seizures. And then you have either an extended lesionectomy tailored with EEG or an EEG-based resection or extended lesionectomy. The other situation is that in which you have no lesion, everything is incongruent, semiology, scalp EEG, PET SPECT, and you have no clear focus or hypothesis, don't implant. And very likely this patient is not a candidate for resective surgery, but maybe a candidate for other types of interventions. And then the final situation where you have a clear lesion with congruous semiology, scalp EEG, but it overlaps eloquent cortex. And in this situation, you need implantation covering the lesion, the surrounding cortex, to map eloquent cortex and plan your surgery accordingly. So this is an algorithm that I find useful when you think about intracranial EEG decisions and what to do. Let's go back to our algorithm. Now we have the generalized seizures or multifocal seizures. We talked about these. And then we started talking about focal seizures, about the need to localize the epileptogenic zone well, and it may be well-defined or not. If it is not well-defined after all these investigations, then you're probably looking at either no surgery or some sort of electrical neuromodulation, either of the peripheral nervous system with vagus nerve or central nervous system with recursive neurostimulation, or perhaps multiple subpial transections, which are extremely ineffective in our experience. What if the epileptogenic zone is well-defined? Well, then the next question is, where is it? If it is eloquent cortex, then you are again back to this box where you can probably not resect. You are limited to neuromodulation or other palliative procedures. If it is, however, not eloquent cortex, then you're looking at a cortical resection, fairly straightforward. If it is not eloquent cortex, but rather it's temporal lobe, then if it's mesial temporal, the question is it bilateral or not? If it is bilateral, you don't have a lot of choices. You probably have either no surgery or recursive neurostimulation or vagus nerve stimulation or deep hippocampal stimulation or something like that, all of which are palliative rather than more definitive. If it is not bilateral, so then the question is the neotemporal, the neocortex of the temporal lobe involved, yes or no? If the neocortex is involved, then you probably need a more extensive resection with an anterior temporal lobe resection, anterior temporal lobectomy of some sort. However, if the temporal neocortex is not involved, then the next question is, what is the primary aim of the surgery? Do you need to choose between minimum invasiveness to limit damage to structures and probably limit the possibility of creating verbal memory or language deficits? Then you're talking about an ablation, a very selective ablation, either with LIT, with electrocoagulation, or so on. If your primary concern is really maximizing the seizure outcome and you have no concerns really about deficits in minimizing invasiveness, then selective amygdalohippocapectomy or anterior temporal lobe resection are indicated. And this finalizes the algorithm of thinking about pre-surgical evaluation of surgery. And to finalize, then, I would like to conclude with these points. Video EEG monitoring is essential in the care of people with epilepsy. Please have a low threshold for video EEG monitoring because it's very useful in many circumstances. In the current situation of restricted availability of resources due to the pandemic, we need to emphasize to our hospital authorities, to our administrators, that video EEG monitoring is an essential service for people with epilepsy. Remember that additional tests have low yield once the target is reached. So choose wisely. Don't do everything just because you have it. It may create discomfort and it's unnecessary for the patient. The case conference is absolutely crucial. So do not proceed without it. It is very important that you do not make decisions on your own or just you and your surgeon or whatever. Involve people, involve multiple disciplines. And then try to establish an algorithm that is adapted to your own setting, whatever your own setting can have, and then adhere to it, follow it. And then if it's not working, review it, review your practice and the results and change your practice accordingly. Thank you so much for your attention and for allowing me to discuss with you a bit of an exposition, a bird's eye view of pre-surgical evaluation and surgery. Thank you very much.
Thank you very much, Professor Wiebe, for the fantastic talk and for sharing your experience and algorithms. We have a few questions. First question would be from myself, actually. What I wanted to ask you is, when do you think is the right time for epilepsy surgery? Does what the stroke doctors use, time is brain, does this apply to epilepsy surgery?
I think that is an extremely important question, Christina. There's increasing evidence that seizures are not good for the brain. There's a very interesting paper by Marian Galovich in Brain, where we produced a little commentary or editorial on that, where there's clear evidence that ongoing seizures are damaging to the brain, and removing the epileptogenic tissue really salvages the rest of the cortex. So yes, time is brain. Time is functional brain. This is really, really important. There is increasing evidence of progressive brain atrophy. There is increasing evidence of severe seizures and creating hippocampal sclerosis and so forth. So yes, time is brain. How early? As early as necessary. If the patient has failed 2 medications correctly used, then I think the patient deserves other options. There is a chance, of course, that the patient may improve with additional medications. However, there are 2 things to consider. Number 1, it's going to take you a while to try everything, and time is brain. Number 2, there is evidence from Dr. Choi in Columbia University that the durability of seizure freedom with these medications decreases over time. And then you're back to the same scenario. And the earlier you operate, the better. As you can see, neurosurgical outcomes are better, surgical outcomes are better, comorbidity and complications are less if you operate early. So early, I would lower the threshold considerably for pre-surgical evaluation. It doesn't mean that the patient is going to have surgery, but you at least have the evaluation at hand.
Thank you very much. Thank you. The next question is, do you think there's any role today for Wada testing?
Well, you know, again, you will have people on different camps on this, right? And you will have people on a camp that says, of course, you know, we do not proceed with temporal lobe epilepsy surgery without a Wada test because this is how we determine language. This is how we determine, you know, risk of memory function and so forth. However, based on the data that I showed you, there is an increasing sense in many centers that the contribution of the Wada test really is minimum. You know, within Canada, you have people doing either, you know, both. You know, there you have centers doing Wada tests in these patients, and you have centers like ours where you probably don't do them at all. You can determine language based on other methods, and you can also determine pretty good the risk of memory decline based on other investigations or an MRI, neuropsychological testing, age, etc. So the answer, if you came to my center, would be no. There really is no role. Perhaps there are centers that provide some rationale for that, but there is no evidence that it contributes.
Thank you. Our next question is, what do you think regarding taking ictal SPECT as some kind of mapping of the ictal network as a diagnostic aid to better understand the ictal network?
Well, I'm not sure I understand the question fully. The role of the ictal SPECT is to identify the seizure onset zone. How does that work? Well, you know, we try to give the injection as early as possible so that you capture the seizure onset as early as possible, and then capture the area that has the accompanying hyperperfusion in that zone. And then we interpret that as being the area where the seizure started. And if you give it too late, then the area may be too broad and it may not be as useful. So that is the main role of the ictal SPECT. It really is probably not a tool for network mapping because the network may be extensive, but it's rather a tool for localizing the maximum area of activity at the beginning of a seizure, therefore seizure onset zone, therefore epileptogenic cortex, therefore an area that you can target with surgery.
Thank you very much. And our last question is, what is the role of DBS compared to VNS or to RNS? Are there any particular cases that would only be eligible for a specific type of stimulation?
Very important question. There are no randomized trials. In fact, there are no comparative trials looking at DBS, meaning deep brain stimulation, versus recursive neurostimulation or versus vagus nerve stimulation. I think that there are many aspects that play into this possibility. The least invasive, you could argue, is the vagus nerve stimulator, and therefore it's easier to implement and easier to do than the technology required, for example, for recursive neurostimulation. In Canada, for example, recursive neurostimulation is still not approved. And I think that this is an important aspect because we cannot offer it, and therefore we are limited to the other situations. What about deep brain stimulation? Well, deep brain stimulation, you know, there's trials demonstrating efficacy in decreasing number of seizures in anterior nucleus thalamus. There is some evidence for hippocampal stimulation, although we had a trial that failed completely and we did not use it or do not use it for many years. And then there are multiple targets for deep brain stimulation. I think that you use the technology that is available to you in general. There are many places in the world where recursive neurostimulation is not available. And then you go to the next best situation, which is, for example, deep brain stimulation or anterior nucleus thalamus stimulation or stimulation of the target or seizure or bilateral hippocampal stimulation, for example. And then you can do vagus nerve stimulation. But I don't think that there are situations where you say, well, you know, this one is better than that one. in a randomized controlled trial. If you have a specific target and you can target it with stimulation, I think that you aim for that. But if not, vagus nerve stimulation is sort of a blanket type of therapy in these patients with multifocal or vague or generalized epilepsies. Yes.
Thank you. And we have a few more questions that come through. Are there any conditions that we may not wait for medical intractability? For instance, DNET. Do you think the need to wait for medically intractable epilepsy may change in the future?
So again, this is a very important question. You know, we tend to if you look at the evidence, you will see there are patients with low-grade lesions, or with even, you know, small focal cortical dysplasias that are well controlled on medications and can be well controlled for many, many years. That is a reality, right? On the other hand, it is quite possible that the seizures will recur and they will become drug resistant. And then by that time, the patient is already 20 years older, or 15 or 30 years older. We tend to offer the patient the possibility of surgery for surgically remediable syndromes. And surgically remediable syndromes are those with low-grade epileptogenic tumors with focal cortical dysplasias and resectable accessible areas, and so forth. So yes, some patients do become seizure-free for prolonged periods of time. However, if the surgery can be offered early, yes, we do consider that, and we do ask the patient to think about that and to think about the risk benefits of surgery, right? And you have to put it into context. It would be really nice, you know, Christina, to do a study looking at a decision analysis and the risk benefit of surgery early for lesions that are not growing, and that epilepsy that is relatively well controlled, and so forth. And, you know, looking into the future with a time horizon of 20 years or 30 years, you know, what would be the cost benefit? This was done, for example, for treatment of the first seizure. There's a really, really neat paper, and I don't want to belabor the point, but there's a really neat paper using a decision modeling and quality adjusted life years. If you treat or if you do not treat a first seizure, and this was done in Boston by Andy Cole in the group. And it's a really important result, because I've always believed that if you have a first seizure, this is not the topic of our discussion today, but if you have a first seizure, you should seriously consider treatment. And those are reasons why you should not, right? And their decision analysis modeling in a robust manner demonstrate that the quality adjusted life years is higher if you treat the first seizure than if you don't. It would be really neat to do something like this in these situations of sort of a low-grade tumors, relatively well-controlled epilepsy, and do a decision analysis of surgery versus no surgery.
Thank you very much. And the last question is from my colleague, Dr. Donoghue, who is asking, what is, in your experience, the reason for lack of seizure freedom in some cases of otherwise typical hippocampal sclerosis?
Very, very important question. So you get into the whole issue of failed surgery for hippocampal sclerosis. And I think that you could categorize these into large groups. So for example, there is adjacent cortex that is not resected, not the entire hippocampal or mesial temporal structures were resected. The second aspect is that is extrahippocampal. It involves also neocortex, and or it could be temporal lobe plus epilepsy. Or the other situation is where it could be bilateral, and you only capture the seizures on the one side, and therefore you missed the additional part. And then the final aspect, of course, is the following, and I think that this is very important. We increasingly recognize that people who fail epilepsy surgery, and it almost doesn't matter which type of surgery it is, temporal lobe, frontal lobe, extrafrontal temporal, fail in two ways. One is early. Within 2 years, the great majority of patients recur, probably within 1 year. And that tells you that there's probably epileptogenic cortex that was not resected. But then there is a number of people that fail late. They're doing well. They do well for 2, 3, 4, 5 years, and then they begin to recur even later on to 6, 8, 9 years. And what that tells you probably is that they have what we call, in a very inappropriate term, maturation of another epileptogenic zone that was there but was not mature enough or active enough. In other words, the brain developed another epileptogenic zone that is sufficient to produce seizures, and we do not understand that well. We don't understand that. If we were able to distinguish those, we would be able to predict and give information to our patients. But I think that there are two types of failure: insufficient resection because we didn't target the epileptogenic zone adequately and we didn't understand it, or development of further networks. I think those are important aspects.
And in the case of, you mentioned bilateral hippocampal sclerosis, where we could only see or capture the unilateral focus, would the PET scan at the time of the evaluation give us more information in regards to that? Is there?
I think that so let me put it this way. Very, very early on, the Margerison and Corsellis, I think back in 1965, and see, this is the advantage of being old. All these old papers, and you can quote them. Brain, I think 1960 or 65, Margerison and Corsellis produced a beautiful diagram of histopathological assessments of hippocampi in autopsy cases. And they found that a huge number of patients had bilateral damage. It's not unilateral, right? So we need to remember this. Hippocampal epilepsy or mesial temporal epilepsy is often bilateral. If you have any evidence from any measures that the contralateral hippocampus is involved, you need to raise a little bit of a flag and say, that hippocampus is involved. It's not only PET. It could be a slight abnormality in the structural MRI. It could be specialized MRI techniques like voxel-based morphometry. It could be spectroscopy. It could be neuropsychological findings where you find that the opposite side is affected and it's not normal. All of those things raise flags as to the lower likelihood of seizure freedom because the other hippocampus is more involved than just minimally.
Thank you. The next question is, which neuropsychiatric parameters should we consider before and after epilepsy surgery?
I don't know what the question means exactly, but if this refers to which tests, I will not talk specifically about tests, but what you need to assess in temporal lobe surgery essentially is verbal memory and nonverbal memory. And whatever the tests are used for that in different centers, there's a recent paper, in fact, from the ILAE Task Force on Diagnostic Commission on neuropsychology that lists tests that are useful for these things. But you need to assess verbal memory, nonverbal memory, because that will tell you whether resecting an area that has good verbal memory or poor verbal memory or visual memory will be affected by surgery. But those are the two elements.
Thank you very much. I think we have concluded with the questions. Thank you very much for an excellent talk, Professor. It was an honor to have you today.
Thank you. It is my pleasure, truly. Thank you for inviting me.
Thank you very much.